Hello friends, today we will talk about oral anti-diabetic drugs. Anti-diabetic drugs were initially called oral hypoglycemic agents. Since all anti-diabetic drugs don't cause hypoglycemia, now their nomenclature is changed to anti-diabetics. A few factors which should be considered when we start anti-diabetic drugs. These are important factors. Before prescribing any anti-diabetic drug to any patient, we must take into account its efficacy, safety profile, side effects profiles, its effects on the weight of the patient, a risk of hypoglycemia, especially drivers, elderly. We have to look into the existing comorbidities in the patients like CKD, hypertension. Cost is a major factor. All patients cannot afford, they can't afford expensive drugs. We have to see the cost of the drug also, and also we have to take into account the patient preferences. All anti-diabetic drugs nowadays, they are, when marketed, they undergo cardiac safety studies, and if they have safe cardiovascular outcome, then only they are brought into the market. So we have to see its long term cardiovascular outcome also. These oral anti-diabetic drugs are classified as insulin sensitizers, insulin secretagogues, alpha glucosidase inhibitors, SGLT2 inhibitors, oral incretin therapy like DPP4 inhibitors, GLP1 receptor agonist, and few others like dopamine agonist like bromocriptine, antimalarials like hydroxychloroquine. They are also given in some special situations. We will take up one by one. First of all, insulin sensitizers. These are the drugs which increase the sensitivity of the insulin at the receptor sites and enhances the glucose uptake by the receptors at the cellular level. The insulin sensitizers are metformin and pioglitazones. Let's talk about the metformin. Metformin belongs to bioguanide family, and it is only bioguanide in use for diabetes. It is the first line drug in type 2 diabetes mellitus. It has multiple actions, multiple benefits, and it has concentration dependent effects in both insulin dependent and insulin independent diabetes. The mechanism of action of metformin, it acts on the PPAR alpha receptors in the mitochondria of the cells. PPAR alpha means peroxisome proliferator activated receptor alpha. These receptors are present in the mitochondria of the cells, and when the metformin is given to the patient, it increases the insulin sensitivity at the cellular level, means it increases the glucose uptake in the cells by the insulin. It inhibits the hepatic gluconeogenesis, means it decreases the hepatic glucose production. It inhibits the glucose mediated signaling. It increases the glucose uptake in the muscles. Its actions are more profound when insulin is partly acting in the patient, for example, patients with insulin resistance. It is very effective in reducing fasting hepatic glucose output, so it mainly reduces the fasting blood sugar level with minimal effects on the postprandial blood sugar. It should be taken with meals or immediately before meal. We have to start with the 500 milligram or 850 milligram dose of metformin on OD basis, and then we can gradually increase the dose. The maximum effective dose approved by the US FDA is 2500 milligram or 2.5 gram, and in European countries it is 3000 milligram or 3 gram. The optimally titrated dose of metformin reduces the fasting glucose by 50 to 90 milligram per deciliter with corresponding decrease in HbA1c by 1 to 2%. Two preparations are available as immediate release and extended release, and they can be given on once a day basis. The immediate release preparation, they carry the risk of hypoglycemia and they have a very high glycemic variability. So these drugs should be avoided. Extended release preparations, they don't show any glycemic variability and there is no risk of hypoglycemia, and as a physician or general practitioner we should give extended release preparation to the patients as it has a very little or no risk of hypoglycemia. The various brands of the metformin which are available in the market are Glycomet SR, Exermet, Metformin SR, Glucoformin XL, Glycophage, Gluconam SR, Cetapin XR, and Metgem. Whenever we give metformin to the patients, 10% of the patients they never tolerate the metformin. The most important side effects are GI intolerance in the form of diarrhea or abdominal discomfort. So in these patients we can reduce the dose or we can put the patients on proton pump inhibitors or antimotility drugs, and if these patients recover with these PPIs or antimotility drugs, metformin can be continued. Otherwise, if patients has persistent diarrhea and abdominal discomfort beside giving this treatment, then we should stop and switch over to other anti-diabetic drug. Metformin also causes anorexia and the weight loss, so which should stop the drug or reduce the dose if the patient is unhappy or doesn't want to lose his weight. It carries metallic taste. Risk of lactic acidosis is very common with high doses of metformin, especially in patients with sepsis, organ dysfunction like CKD, congestive heart failure. And whenever a patient is admitted in ICU or in the hospital settings with features of sepsis, shock or organ failure, we should discontinue the metformin. Vitamin B12 malabsorption is very common with metformin use. It is because of decreased absorption of the complex of intrinsic factor and cobalamin in the terminal ileum. So the patients who are put on metformin, they should be advised yearly monitoring of vitamin B12, especially in those patients who are pure vegetarian or the patients in whom malabsorption is a predominant feature. Because of vitamin B12 deficiency, the patients can have neuropathic like symptoms, paresthesia, numbness, neuropathic pain, and these features may be due to vitamin B12 deficiency in the patients who are on long-term use of metformin. So such patient should be given supplement, vitamin B12 supplement. Contraindications of the metformins are renal impairment, especially in the patients with low eGFR, that is less than 35 GFR, or increased creatinine, serum creatinine level more than 1.7. In such patients we should not give metformin. Metformin should not be given in patients with cardiac failure, in patients with sepsis or shock, or in patients with excessive weight loss. And if the patient has features of metabolic acidosis, we should not give metformin because it will further lead to enhancement of the acidosis, lactic acidosis. Metformin in high doses suppresses the mitochondrial respiratory chain in the cells. This respiratory chain basically is responsible for ATP or energy generation, and when metformin is given in high concentration, it stops this respiratory chain and it leads to anaerobic metabolism, and because of anaerobic metabolism there is increased production of the lactates, which leads to lactic acidosis. So we should avoid uh, this metformin in patient with sepsis, shock, or decreased organ perfusion because of risk of metabolic acidosis or lactic acidosis. In nephropathic patients or patient with CKD, if the patient has, we have to basically modify or titrate the dose of metformin in CKD patient or nephropathy. If the patient's eGFR is more than 45 and serum creatinine level less than 1.4, we can continue the metformin. If eGFR is between 30 to 45 and serum creatinine 1.4 to 1.7, don't start in new patients, or we have to reduce the dose if it is already being taken by the patients. If eGFR is less than 35 and serum creatinine is more than 1.7, we should not give metformin, and if it is already given in the patients and he has serum creatinine more than 1.7 or eGFR less than 35, we should stop metformin. There are some off-label uses of metformin, but there is no formal indication for pre-diabetes, type 1 diabetes, gestational diabetes, polycystic ovarian syndrome, or non-alcoholic fatty liver disease. Some physicians or general practitioners do use metformin in these conditions, but there are no formal indication, but they are being used as off-label. This was about the metformin. In next topic, I will discuss about the another insulin sensitizer, that is pioglitazone. Thank you very much.